Good evening, everybody. Today I'll be presenting a study that was published in the New England Journal of Medicine on October 25th, 2023, titled Inhaled Amikacin to Prevent Ventilator-Associated Pneumonia. To begin with, as a background, ventilator-associated pneumonia is one of the most frequent presentations of hospital-acquired infection, with an estimated incidence of 2 to 30 episodes per day per 1,000 days of mechanical ventilation, which ranges up to 40% of the intubated critically ill patients as well. The mechanism is via the microaspirations around the ET cuff and the biofilm formation again around the endotracheal tube as well, with attributable mortality risks that have been told prior been up to 13% also. So we do know that because of ventilator-associated pneumonia, there is an increased systemic antibiotic consumption, increased duration of mechanical ventilation, ICU stay as well as costs. So the research question was whether preventive inhaled antibiotics may reduce the incidence of ventilator-associated pneumonia. And the rationale for this utilization was that overt ventilator-associated pneumonia generally occurs clinically, at least, is seen at 7 days of ventilation, and thereby it provides a therapeutic window of opportunity to hinder this infection early on itself. And the use of inhaled antibiotic will see to it that there's a high concentration that is achieved in the tracheobronchial tree, lung parenchyma, and also the biofilm itself. So their hypothesis was a 3-day course of inhaled amikacin initiated after the 3rd day of invasive mechanical ventilation might reduce the incidence of ventilator-associated pneumonia. So previous studies that they have quoted were that is a meta-analysis which was published in the Journal of Critical Care in 2018. This is a meta-analysis which involves around 6 studies. They're smaller in size, which are observational also, wherein they have used prophylactic antibiotics where they have either intratracheal injection or nebulization. Both have been used. Firstly, they found that nebulization is a better strategy for sure for reduction in VAP. And they also found that use of prophylactic antibiotics did reduce the VAP with an odds ratio of 0.53. As we can see from a forest plot, it is showing that it is favoring antibiotics via the tracheobronchial tree in this meta-analysis. So the methods of this study, which is the Amikacin inhaled study, it involved investigator-initiated study, which was multi-centered. It included almost 19 ICUs, which were in France. It was a double-blinded study, which was an RCT of superiority, that was what is being tested, conducted under the Regional University Hospital of Centers. And it was funded by a grant which was given by their country's Ministry of Health itself, with an independent data and safety monitoring board as well. Their inclusion criteria included adult patients 18 and above and patients who were already on invasive mechanical ventilation for at least 3 days. They had to have an informed consent that was signed, and the patients were generally going to be covered under the French Social Security as well. And a negative pregnancy test was required at the time of inclusion for patients who were thought to be of a childbearing potential. Patients who were excluded were patients who were already on 96 hours of invasive mechanical ventilation, who already had suspected or confirmed VAP, because the idea was to use prophylactic antibiotics. In patients who already had severe AKI without RRT, according to the KDIGO, grade 2 and 3 and above were all included. Patients who already had CKD with a GFR at baseline itself of less than 30 ml per minute. Patients with tracheostomy tube who were also going to be planned for extubation in the next 24 hours. And patients who already had systemic antibiotics in the form of aminoglycosides that are being utilized. So the intervention included nebulization. It was going to be given once a day for 3 consecutive days. And this was after 3 days of already being on mechanical ventilation. So it would be day 4, 5 and 6 of invasive mechanical ventilation. They have used the apparatus of a vibrating mesh nebulizer of the Aerogen company. And the drug amikacin was given of a dose of 20 mg per kg of the ideal body weight. The preparation of either the drug or the placebo was done by staff who was not involved in the patient care or in the drug trial as well. And all the nebulizers were taped with opaque stickers to see to it that the study remained blinded itself, and concentration of amikacin measurement also was not allowed. The nebulizer was positioned upstream in the inspiratory limb of the ventilator. When it came to the controlled, a same amount of the 0.9% NS was going to be utilized for the same amount of times also, that is once a day, 3 consecutive days, for day 4, 5, and 6 of invasive mechanical ventilation. And the physician was allowed to do how he would generally practice for the patient when it comes to ventilator settings, sedation, muscle relaxation, and whatever were the VAP bundles that were going to be followed in the centers itself, which are anyways in concordance with the international guidelines. For the randomization, they followed a 1:1 ratio, wherein there was stratification first that was done based on the trial center and whether systemic antibiotics were given also. Allocation concealment was through a central computerized system only. So the generation also as well as allocation was all through computerized system itself. For the blocks that were going to be formed after randomization, they included 4 patients totally. And this block size also and the inclusion in the block was all done by a statistician who was not involved in the trial as well. So a total of 50,000 patients got admitted in the ICU during the stay in the study of 2017 to 2021. And in that, 6,419 actually underwent endotracheal intubation and mechanical ventilation for more than 48 hours. After 5,569 patients who were excluded after utilizing the exclusion criteria, 850 actually underwent randomization, with 420 in the Amikacin group and 430 in the placebo group. So they saw that around 5 patients didn't receive amikacin and 2% did not receive the placebo in their respective groups. But since this was the intention to treat analysis that was going to be planned, 417 total in the amikacin group and 430 in the placebo group were taken into consideration. So the definitions that were followed to see all of the outcomes, the primary outcome being VAP and the rest of them being ventilator associated complications and events, they have given like strict guidelines or definitions that they have followed, which are again in consensus with what is the international IDSA guidelines as well. So VAP was going to be defined if they got a positive quantitative bacterial culture in the pulmonary sample and at least 2 of the following with a chest X-ray that is showing a new infiltrate for sure. The 2 findings had to be in the 4, which is hyperleukocytosis, leukopenia, fever, and purulent secretion. Ventilator associated condition was wherein there was worsening of oxygenation in the last 2 days after a stabilization period. It was called infection related if there was associated clinical signs of infection as well. And it was called possible VAP if along with the infection related clinical signs and the oxygenation worsening in the last 2 days, and we had some kind of bacterial component that could be documented in the form of biomarkers for the patient. So this would become possible VAP then. So their plan was to do outcomes. The primary outcome was the first episode of VAP from the time of randomization to day 28. And the secondary outcomes would include from the time of randomization till day 28, the incidence density, which is per 1,000 days of invasive mechanical ventilation of adjudicated VAP. Adjudicated means that after the data would be achieved, they would see to it that it is compliant with whatever their initial definitions were. They wanted to see to it that it fell under actual VAP for sure. Ventilator associated events included ventilator associated condition or complications, infection related VAC, as well as possible VAP. The number of days that were going to be having one at least systemic antibiotic, the total number of antibiotic days, the days that the patient would be on mechanical ventilation, the number of days the patient would be in the ICU or in the hospital till 90 days, mortality that would be there at 28 days and 90 days, and what was the safety profile with this utilization of nebulized amikacin. For the statistical analysis, they came up with a sample size of 850. This was based on their own study previously, wherein they found that the incidence of VAP in their groups itself, in their ICUs, they expected the incidence of VAP to be 6% in the amikacin group and 12% in the placebo group. So the sample size of 850 came with a power of 80% with a two-sided alpha level of 0.05. And as I mentioned, the analysis was to be done with an intention to treat principle only. So initially for the primary outcome, which was time from randomization to first VAP, they wanted to do a cumulative incidence curve, wherein they would come up with Cox regression they would find between the outcome and the initial variables. And then after that, they would come up with Kaplan-Meier survival curves that are generally seen in general critical care studies. But they found that whatever was the hazard ratio, it was not being constant all throughout the time. As the time went on after the nebulization, the incidence for VAP would have increased. So therefore, they could not utilize this, since Cox regression says that the whole time that the patient has to have this risk, it should be constant all over that time period that we're taking. So instead, they had gone ahead with restricted mean survival time. This allowed for between group analysis and also excluded any competing events like death and extubation rate also. The rest of the secondary outcomes were to be given in the form of hazard ratio, which was a time to event analysis. And the other secondary outcomes were going to be termed exploratory only, because they did not adjust for multiplicity. Since there were so many secondary outcomes and they had chosen already an alpha value of 0.05, they didn't really put any multiplicity correction for it. So they had to term it as exploratory only. The other quantitative outcomes were to be given in the form of median differences, binary outcomes in the form of proportion differences, and whatever pre-specified subgroups that they have planned for, each of them also they were going to give a restricted mean survival time for VAP. So to come to the baseline characteristics, the patient group was such that both the amikacin and the placebo group had an age of around 60 years, with an increased male preponderance of around 68%. And most of the patients were medical ICU admission patients, with their primary diagnosis to be infection itself. So to come to the results, the primary outcome showed that the first VAP episode from the time of randomization to day 28 was 15% in the amikacin group and 22% in the placebo group, thereby showing in the form of restricted mean survival time a 1.5 days difference, and this was statistically significant in the form of a p-value of 0.004. So, as you can see in this graph, which is the cumulative incidence of VAP over time of days of since intubation, it was seen that the first episode of VAP after randomization occurred. It was seen that the amikacin group took 10 days versus placebo group, which took 9 days. And this interquartile range also was quite wide. So, it also could mean that some of the patients also had days of 16 days that was free from VAP in the amikacin group versus like 12 days would be in the placebo group. So the restricted mean survival time, which is the average time over this interquartile range, was shown to be 1.5 days between the amikacin group and the placebo group. Then they had also made adjustment for the risk exposure. It means that while the amount of time of the intubation also was to be taken into consideration, and this definitely will give a more true risk exposure outcome. So the VAP incidence rate was seen that in 16 patients only were seen in VAP cases for amikacin group versus 23 VAP cases when it came to the placebo group. And they took a rate ratio, which is the rate in the amikacin divided by the placebo group, which showed 0.68 as the rate ratio. And this means that the risk of developing VAP in the patients of the amikacin group was 32% lesser than the placebo group itself. The other key secondary outcomes showed that the first VAP in patients who had gram-negative bacteria was also lower in the amikacin group, which is 7% versus 14%, with a restricted mean survival time of 1.9 days. The other ventilator-associated events in the form of ventilator-associated condition, infection-related ventilator-associated complication, and the possible VAP also showed a lower hazard ratio in the patients who were amikacin group, as in there was a lower risk of getting VAP in these patients also. The other secondary outcomes in the form of days that are required for at least one antibiotic, the total antibiotic days, and whether they were able to achieve earlier SBT also was not seen in both the groups. Statistically, it was insignificant, wherein the hazard ratios were almost 1. So there wasn't much difference between the two groups. And when it came to the incidence for the number of days on invasive mechanical ventilation or the median time in the hospital or the mortality, both of these were just given in the form of difference itself, and there was no difference in the absolute numbers. So ventilator-associated complications when seen between amikacin group and the placebo group, as seen in this graph, it was seen that the patient had a hazard ratio of 0.79. This means that the groups which received amikacin as their prophylactic antibiotic, 21% lower risk of developing VAC was seen. In infection-related ventilator-associated complications, the amikacin group showed 18% versus 26%. And again, the hazard ratio, as you can see, this large gap that is there between the two was 0.66, which means that the possibility of getting infection-related VAC was 34% lesser in patients who were on neb amikacin. When it came to possible VAC among the patients who had ventilator-associated events, this was 5% versus the double, which is 10% in the placebo group, which showed almost 54% reduction in the possible VAP also. So this large gap that is there is showing that there is a decreased incidence of the ventilator-associated pneumonia in these patients who were on prophylactic amikacin. The other studies that were to be included was the safety outcomes. It was in the form of serious adverse events, respiratory events also, and acute kidney injury. It was seen that they both did not differ from each other and there was no statistical difference between the two. Again, the possibility of having resistance because of utilization of this nebulization of amikacin was also insignificantly different between the two. Acute kidney injury also was not different, thinking aminoglycoside being nephrotoxic did not differ between the two, that is the amikacin and the placebo group. So therefore, in this study, a 3-day course of amikacin did reduce the burden of ventilator-associated pneumonia by 28 days when compared to the placebo group. And such a result was also seen in the secondary outcomes in the form of ventilator-associated events. The serious adverse events also were lesser than 2% in this group. So why did they choose 3 days and why did they choose this inhaled antibiotics was them trying to balance the efficacy versus the feasibility. It was seen that they've chosen 3 days because they felt that at 7 days we're getting clinical VAP for sure. So an early control for the spread of the tracheobronchial bacteria that is there before it even causes pneumonia would be a good idea. And earlier than 3 days, as in 0 days or 1 days, would again become unnecessary for a patient who anyways is going to get extubated. In patients who are inhaled antibiotics, why they have chosen is because, again, it would cause a high lung concentration and thereby maybe reduce the resistance with the utilization of systemic exposure of antibiotics. And this was the only way wherein the antibiotic could reach the biofilm, which is thought to be one of the reasons for VAP. Previous studies have shown the utilization of colistin and ceftazidime as well as amikacin as well. This is a study which was a non-RCT, an observational study only of 600 surgical ICU patients that was done wherein they have used colistin neb for prevention of nosocomial bronchopneumonia. They divided them into survivors and non-survivors, even after the VAP, whatever might be the reason for their mortality. In the survivors, they utilized BAL to find out the nosocomial bronchopneumonia, and in non-survivors, they went with post-mortem biopsy itself. In that, they found that the utilization of colistin nebs decreased the possibility of nosocomial bronchopneumonia, and this was statistically significant as well. And there was no emergence of colistin-resistant organisms in both of these patients. Again, when the utilization of colistin was tried for in an RCT, which was published in 2015 in the European Journal of Respiration, it was seen that VAP did not reduce between the two. Though VAP incidence density rate, the GNB related VAP, multi-drug resistant VAP, and VAP due to Acinetobacter was all reduced, and even ventilator associated tracheobronchitis as well as colonization while utilization of this 10 days of colistin neb did decrease the colonization. So this could show that there is a reduction in the VAP for these patients who are high risk maybe. When they use ceftazidime nebulization, this was a 2002 study. They found that at day 14 as well as the total ICU stay, there was a reduction in VAP frequency. This non-shaded bar is the ceftazidime group, wherein it is showing around 15% of VAP frequency at day 14 versus 55 when it comes to the total ICU stay. And here in the total ICU stay, it is showing around 30% versus 65%. And when the number of patients without VAP is seen, this dashed line is the ceftazidime. Almost a 54% difference was seen in these patients. But when similar studies were done again, there were in trauma patients, there was no statistically significant difference seen between the two. So again, there is always a mixed report when we come to this nebulization of antibiotics. When it comes to this amikacin antibiotic itself, the inhale study, which was published in the Lancet in 2020, it was utilized for already established VAP for treatment of VAP, basically. And they found that there was no between group difference between the two. 75% of them had treatment success in both the groups, and unsuccessful treatment was seen in 25% of the group, thereby not being statistically significant. But this was a patient group which was already established. So they wanted to see to it whether the prophylactic use could be helpful in these patients. Now, the study, when it comes to the limitation, it did show a modest effect size, wherein there was a reduction in VAP from 15 to 22%. But because VAP is so multifactorial, how much of it is limited to the utilization of amikacin again cannot be extrapolated. It did look into a very short follow-up time of 28 days. Therefore, longer-term outcomes in the form of mortality or rehospitalization could not be assessed. This study population was a medical ICU population, and it did not include immunocompromised or neutropenic or pediatric patients. So, how can we use this in these particular patient groups? Again, cannot be utilized. Uncertain impact on the hard outcomes. They did utilize VAP, but it is not a patient-centered outcome. Whether the reduction in this VAP is going to decrease death or decrease the length of stay in the ICU is not really known. So this is not really a patient-centered outcome. When it comes to the strengths of the study, it is an RCT and therefore it is a gold standard for research which reduces bias and confoundings. It is a large enough size of almost around 800 patients, so it is going to detect meaningful differences. It being multi-centered in almost 19 ICUs that have been utilized, it improves the generalizability of the use of amikacin as an EB. And it did utilize a primary outcome which has real world impact, which is ventilator associated pneumonia. Because they have used restricted mean survival time and hazard ratio, all of these are over a particular time period. We know that patients who are going to be on invasive mechanical ventilation during that time only are at increased risk of ventilator associated pneumonia. Thereby, using such a time to event analysis is helpful than just giving incidence, wherein it is not taking into consideration how long the patient is actually on the mechanical ventilation. Other statistically significant endpoints that were taken other than VAP, which was VAC and IVAC, also had shown a reduction in their incidence, which reinforces that VAP definitely has reduced, and this primary finding is a statistically significant one. So, to conclude, among the patients who have received invasive mechanical ventilation for at least 3 days, a subsequent 3-day course of preventive inhaled amikacin did reduce the burden of ventilator associated pneumonia during the 28 days of their follow up. So to use this clinically or no, the IDSA till now, what is recent is till the 2016 for patients who are VAP because of gram-negative bacilli, they have told which is susceptible only to aminoglycosides or polymyxins. They have asked to add inhaled antibiotics as a last resort for patients who are on already IV therapy, but this is a weak recommendation based on very low quality evidence. So based on this study, maybe inhaled amikacin has shown, since it has shown VAP reduction, it can be utilized in specific high-risk populations in the form of patients who are going to be anyways on prolonged ventilation, patients who are in an ICU which has already shown high rates of gram-negative VAP, or patients who already are colonizers or are shown to have local high rates of MDR also. In the critical appraisal, the study is valid for sure. It is questioned a relevant study. I mean, the research question is relevant and focused for sure. And the study design is definitely appropriate, wherein they have used an RCT and
Isha,
the randomization. Yes, sir.
Isha, we can stop here. We can discuss before going for the critical appraisal.
Okay. Okay, sir.
Does that-
Yeah,
Could you continue the critical appraisal or will...
I think we'll little bit discuss about the
Yes.
clinical outcome, and then we'll go for the
Yes.
study kind of this thing is. Of course, this is a relevant in our situation. So, what do you think? Like, we can generalize this effect in our day-to-day practice?
So generalizing it is going to become difficult. Actually, the study didn't tell us exactly whether this patients, what kind of organisms they have, whether what kind of resistance are they having. Since we anyways will receive patients who are going to be MDR when by the time they do come to the ICU, wherein they're requiring ventilator support for sure. When they do get their VAP, they generally do have MDR bugs itself. So whether we can utilize in them or no, they've not specified whether they have used it for a specific organism or no. So that is kind of a fallacy in the study. But for patients, since we are saying that we are having MDR organisms, we can utilize it, sir. There's no risk that they have shown in the study, wherein they did not find an increase in AKI. So nephrotoxicity can be ruled out. And they have not shown any respiratory complications in the form of bronchospasm or increased FiO2 requirement because of the use of amikacin itself. So that way it is helpful for sure, especially in the ICU wherein we are thinking that the patient anyways will have MDR organisms to begin with.
Uh, uh,
Okay.
Lorisa, I have a point before that discuss. First of all, the diagnosis of VAP. So they have used with the logic that the upper respiratory flora is going to be microaspirated and that is leading to VAP. Okay. So the diagnosis of VAP is itself by sputum culture. Okay.
Yes, sir.
So it will be very difficult whether to say that the normal organisms that are present in the normal flora, is, the upper flora, upper respiratory tract only is going to be responsible for the further development of the VAP. First of all, that. Also the
Yes.
diagnosis of VAP with sputum culture and by X-ray, they have used X-ray also.
Yes,
For
sir. Yes.
it is like it may be a overdiagnosis or a underdiagnosis like thing.
Hmm.
So it is very difficult to justify that. So if you take the diagnosis, take the terminology like possible VAP, probable VAP, which are
Yes.
mostly for statistical for the epidemiological purposes, then
Yes.
it is a different thing. But actual VAP with sputum culture and X-ray it will be difficult.
Yes,
Yes,
sir.
doctor.
Yes, sir.
Yes, sir.
Yeah. So, um, especially for our listener, in a general approach, whenever we come across any paper, any study, so we divide the major generalizability in the two part. Critical appraisal we do to know whatever conclusion is made based upon the our research is it is a truth or closer to the truth. That is a critical appraisal part. Second part in the generalizability, though it is a truth, of course, which are a checklist based upon the other tools. But this truth is really going to affect in my clinical practice or not? That is the second part comes into the play. So that's why whenever somebody raise this question regarding to the generalizability, so our understanding should be very clear. It is based upon the two major domain. One is whatever we get the answer, there is a doubtful in it's a truthfulness or the closer to the truth. Then that affirmative answer is rejected. If we believe it is a truth, then come to this truth is really matters to us or not. That's a very important. So in that again, when we see a appraisal of the paper, then again it comes to the two part. One is the clinical part, and second is the methodology along with the statistical. So first and foremost, Dr. Bikash is the a web definition and web identification itself is the all the time it is not a uniform. So we enter into that question, which is the foundation of our this research itself is not that much robust over there. Say for example, if I compare something for the hypocalcemia and some outcome, so that is a laboratorical base so much robust over there. If I say suppose hypercalcemia like a 12 to 15 is the is a mild, so it will be mild because it is a laboratory base and very much robust. Here the web
Object.
definition and all this comes to the play, so that is a still we accept based upon that. Then it comes to the your methodology over there. So that is a part of the critical appraisal, which we, and that is the first and foremost, because whatever we get the conclusion, it is the conclusion of this paper, not the conclusion of the universe. So once we believe this paper is really fit enough to conclude this, and I believe in this conclusion, then we'll go for the our clinical practice population and situation to go for the generalizing. That was a mainly principle. That's why I asked you, and then obviously we'll go for the it's a critical appraisal. Just and critical appraisal is like you are a skeptical person, so you begin with the all the thing doubting, and once you clear the doubt and you believe it is there. So that is the principle of our audience, and what is the aim for general club is this only, so that once we understand why we go through all the methodology to get ourselves convinced, whatever conclusion is made, based upon that this conclusion is true conclusion or near to the truth. That is a very broad sense of yes, Dr. Vikas, anything you want, and then we'll go for the stepwise that what I talked about, the basic philosophy and the principle about that, then we'll narrow down to the exact steps about this. Meanwhile,
So,
we will discuss a one uh, most probably printing mistake is there in this paper. So Isha, just try to find out, and then I'll let you know where is the printing mistake over there. In the last, I will tell you. Yes, Doctor.
so that is very correct, Rajendra. One more issue before you go to the critical appraisal part is like the use of antibiotics for preventive purposes of VAP. So, if at all it is found that not only this amikacin or any other drug you can utilize for a preventive purpose, maybe initial stages we have a good result, but is it going to affect your antibiogram or antibiotic stewardship in a long-term process? Because uh, after some time, there, if you use, suppose amikacin is very much effective preventive, we have, and everybody started using amikacin in relation for 3 to 5 days to 7 days from the day one of mechanical ventilation. So, and if it is found to be good enough, but that will be very short-lived. I doubt if in longer term it will be with a generalized used that much effective. So, using certain antibiotic as a preventive measure, how much there are a lot of studies coming of time to time whether septadine is effective, whether amikacin is effective. So that is another aspect I want to discuss. Whether, in my opinion, it is maybe if these studies are also been done, but whether they are going to have a long-term effect on the ICU population is doubtful. Yes, sir.
So let's first we'll go for the. So I guess you understood the principle, Dr. Isha.
Yes,
First,
sir.
we
Yes, sir.
just test this paper, whether it is
Mm,
telling truth or not. Then we'll
mm,
next just thinking, even it is a truth, then how does it matter or fitting in our situation? So the
mm,
first is
mm,
just to
mm,
really know
mm,
this piece of paper is good enough to conclude this thing. So
mm.
for that we are having a appraisal.
Yes.
So we can go for the appraisal.
Okay. Shall I
Okay.
start the appraisal then, sir?
Yeah, yeah.
Mm. So, like you have discussed, sir, we'll first discuss whether the study itself was valid to begin with. Is it really something that we need to question? Or also the methodology of the study itself, whether it is good or no. So, for the validity of the study, the research question is relevant and focused for sure. We always are thinking about how to prevent this thing, ventilator-associated pneumonia. They were thinking of the same, and they have come up with the utilization of aminoglycoside nebulization. The design that they thought of for the research question was a randomized control trial. Again, this being gold standard for any kind of interventional therapy should be a good enough design for this question as well. They did assign the participants randomized only. They have used computer generated, so there is no people involvement in it. So that completely removes the possibility of defects in the randomization itself. With the methodology, they did give their protocol and analysis prior itself. They did tell that if they weren't able to find any kind of possibility of Cox regression, if they were not able to tell, they will come up and utilize a restricted mean survival difference that was already mentioned in their previous protocol itself when they had published it. And they went ahead with allocation concealment and double blinding, wherein the physicians did not know and the patient did not know. Actually, even the statistician who was involved in the randomization also was not knowing of what was going on. When the this thing whole procedure was going on as well, the randomization was seen to it. The staff that was involved in utilization of this nebulization who made it also was blinded, was not included in the study. So those things were definitely taken care of. It was funded by their own country's Ministry of Health, so that financial kind of independence was there for them for sure. Baseline characters were similar between the two. Both of them had a similar starting point for AKI, as in their creatinine. They both were medical groups only, and they both also came with respiratory infection only as their primary diagnosis. While looking through the study grossly, there is no possible bias or confounding factors. They have told about that confounding in their limitations to begin with. And if they are saying that they are taking multiple exploratory outcomes, that also they have told, because it is not been corrected for this multiplication, they are not including them as an actual outcome. So that also has been told by them prior itself. And the groups, both of them have received the same level of care since the physicians didn't really know. So this part of whether the study has been conducted in a true valid form seems grossly okay, sir, based on these parameters. Now, whether the results of what has come, the sample size estimation was based on their own local population in incidence of VAP in their own study. So that means that whatever they are looking for and the sample size to begin with also was calculated correctly. The statistical tests also they have mentioned prior, and how they want to get those outcomes also were defined properly as well. They did tell about confidence intervals if they were talking about both hazard ratio or rate ratio also. And if they did had dropouts, like in the form of not receiving the nebulization, 5 of them didn't receive in the Amikacin group and 2 of them did not receive in the placebo group. Those were included because this was intention to treat. Other than that, on follow-up, there was no loss in follow-up, sir. Now, when it is whether this can be taken, whatever results they have gotten, how much of it can be clinically applicable, they have discussed their limitations also. They're saying that they did not look into a long-term outcome. They just said VAP incidence in the form of restricted mean survival time. Whether now this 1.5 days difference, is it really going to make a difference for the future of the patient in the form of mortality or ICU stay? That cannot be looked into because they only looked for a follow-up time of 28 days. So they did mention that in their study limitations, and whether they can utilize this on a a broader population, they themselves have said that it is a limitation of their own. And whether we can utilize it for our local population or no, based on the fact that what is the risk versus benefit, as this is what I have gauged, sir. Thinking that MDR organisms are going to be a bigger problem for us when we are talking about VAP, wherein we then lead to it reaches a point wherein it becomes difficult to treat also. Maybe having a prophylactic antibiotic could help if we are seeing that there is no risk from the addition of this drug. And that's what IDSA also had told, wherein he was they have told utilization of these nebs in the form of like a last resort could definitely be helpful when it comes to treatment, but it being like a primary drug again is questionable only, sir.
So, Dr. Isha, generalizability will little bit discuss later on.
Yes,
So,
yes,
question comes once we critically appraise. So, the conclusion was made by the author. You are
yes.
convinced with the conclusion, or how you conclude it. So, what is the conclusion of this thing is
He's
one
saying that
patient.
the burden of ventilator associated pneumonia at least is lesser based on the time of occurrence of the ventilator associated pneumonia.
In their
Both
study
the,
population.
yes, sir,
Their
in their study. Yes, sir.
study population. So that is very, very important.
Mm,
So first of all, we believe in conclusion. Of course, we believe in conclusion, but
mm.
it is concluded from their study population. So
Yes,
we can't conclude Amikacin supplemented fourth, fifth, and sixth day will reduce the VAP rate
yes.
in a stand-alone sentence. It has shown reduction in the VAP rate
Mm,
in their studied population. Now, so that we believe, and for that that format is required, whether the methodology is right and this thing, and that would be a standard met, steps or a standard checkbox
yes,
universally accepted. When we comes to the generalizability, of course they mention the generalizability, but generalizability would be a very, very personal matter for you. So our generalizability point may differ. We'll discuss that thing in our this thing. So whether your research has been done in a way to conclude, so be reasonably okay. Bias were taken very well, but the here come to the when generalizability. The first and foremost is actually see their first see their stuff, and then we'll come to the R situation.
yes, sir.
So then see the inclusion and exclusion criteria. So yeah, their exclusion criteria was severe acute renal failure,
Mm,
not requiring and the CKD,
yes, sir.
okay,
Mm,
and the tracheostomy tube.
mm,
So these are, and those patients we are thinking about are this thing is these are the major contributor and that was excluded from that.
mm,
And these are the major patient related factor which comes into the play web. So that's why their study population
mm.
may not be a true representation of what we are seeing in the clinical practice. If you
Yes, sir.
exclude really,
Mm,
I'm sure in your clinical practice you can count the on the finger of those patients who actually
mm,
meet the
mm.
inclusion criteria in your clinical practice. Because
True.
and first for and second point, most of the time we have a problem with the late VAP and mostly the tracheostomies and that
Mm,
population was excluded. That is the reason. That again, that
mm.
doesn't mean who is right and wrong, and that the problem is the generalizability. That's the one.
Yes.
And the second, which you already uh, told me, told us related to the antibiogram, because the infection whatever you do is the completely based upon the what is your epidemiological data.
Local. Yes.
It's purely whatever is going to infect, and then thing is in our clinical practice, and basic principle, a basic principle of infection, definitely whenever we use the antibiotic or antimicrobial agent, the virulent organism must be sensitive to that. In vitro or in vivo or not at all, maybe a greater concentration over there. So at least the agent must have capability to kill this organism. Otherwise, it's not the kind of a treatment which increases the host uh, ability to fight the infection. So technically, here the resistance comes to the play. So
Mm,
again, our antibiogram is not really fitting into that.
yes,
So,
sir.
so that is the second reason apart from the. So and second, these are the most important reason. Third reason, which is the otherwise common in all the clinical trial, but here become more relevant, that I'm giving clue, just out of it comes to your mind, that is applicable to the all clinical trial. What is the third reason? Third reason is the Hawthorne effect.
Okay.
And here is the prophylactical bundle and all these things. Web prevention bundle is a very, very important, and the sets of the things are there. And in clinical practice, if you go for the compliance, round the clock compliance of the web prevention bundle itself is a very much challenging. And when you do the study, the Hawthorne effect is, you must be knowing, this is the inherent
Yes.
problem with the clinical trial. Somebody seeing, then your behavior and the things
They'll become
becomes
even
once
further.
once we register these patients for the trial, they will be get an excellent application of the web bundle because they are the part of the trial.
Yes, yes.
That may also confound. So much variables over there, the preventive strategy and the a lot of healthcare system, nursing, clinician behavior comes into the play and all these things. So therefore we may doubt, it may work in our clinical practice, it may or may not give us the results which this paper has shown. So that is my take. As that again, a few things are uncertain. Don't convert uncertainty into the negative outcome of it. It's uncertain. May work for the patient, some patient may not work for the other patients. That's why the implication is this: I cannot take it as a introduction of any strategy in routine practice of the institute. It may be individualized patient. I may consider this step, but I can't make a protocol in my ICU that all patients should receive the amikacin based upon this. That is the our take at this moment. Yes, Dr. Bikash, you want to add something?
No, sir, that is definitely very well said. The generalizability to our setup or our local population is definitely doubtful. These are the reasons for that. Also, even if their result also, the number of ventilator days are not, number of ICU stay or number of ventilator days also that don't.
Didn't change.
If it is really decreasing the VAP, so it should at least decrease the number of ventilator days or ultimately number of ICU stays. So that is uh, ultimately the clinical significance is not there if it is not decreasing those things.
Yeah, but the one escape route author can say, my study is not powered for that. So my
Yes,
primary endpoint was that's only, that's why either it is not there or it may be there, but my study is not powered for that.
yes. But
Because the primary
they
endpoint
have
was here is web prevention, not the 28 days mortality.
definitely. So they have started the study with the incidence of 14 or how many percent of VAP incident, but it is comes to around 32%.
So
Yes, sir.
I think, if I remember correctly, 6 and 12% they projected it,
Yes, sir. Yes, sir.
and ultimately they end up with the 15 and 30%. I think
Yes, yes, sir.
30%.
for hypothesis they projected 6 or 12, if I remember correctly.
Yes, sir. 6 and 12 for the sample size selection, sir. They've shown
For the sample size
15% in
calculation,
amikacin and
yeah.
22 in placebo, sir.
So they'll end up with this 15 and this thing is.
30%. So although the incidents have been varying from 15 to 40%, 32 is in mostly our side. So those
So
ICU
one,
where the insurance is less, so how much it is going to, so why this 32%, that is also we don't know whether the adherence to VAP bundle or the look, because it can differ. The VAP insurance definitely can differ in different setups, depending on the patient population.
even
But
population, patient population.
yeah, so where suppose some ICU has a very strict adherence to VAP bundles and it has an incidence around maybe 8, 10, 12%. So how much it will be beneficial, that setting also has not been, because something where it is not taken care of preventive or whether it is taken care of excellent oral care and other adherence. whether going to affect this result or not, that is also one of the concerns.
Second, for this outcome, possibility to get the answer of our research question, so much mixed population is actually negative point over here. Because a long-term stroke and all these things behave in a different way. So, and 5, 6, 8, 10% of the different kind of a population may not give a. There's a two different kind of this thing. We previously discussed about that also. If you want to get a precise answer of your research question, then your generalizability goes down. And if the precision goes down, then your generalizability increases over there. So you just want to have the answer of this research question, so that your patient population should be very, very narrow in terms of the heterogeneity over there. So you get a very precise answer for your this thing is. So that is the aim to get the answer of your research question. And when it comes to the generalizability, definitely the question comes out of the study population that much only, so that we require. So that is a typical limitation of the research. When you want to generalize, then you have to take a heterogeneous populations. Then probably your answer of the research question may be skewed, may not be very precisely closer to the truth, or may or may not. So that is a problem. I told you one printing mistake is there. If you see the figure 3, and you have shown in your presentation also, the A, B, and C, ventilator associated complication. It is not the complication; it is a condition only.
Condition,
So
yes.
the right side is a complication. So when VAC is not the ventilator associated complication is a very generic term. So somehow it is a printing mistake. Author actually should write here in the graph ventilator associated condition, because you
Conditions.
go the legend of this graph. So it means a ventilator associated condition rather than a complication.
Yes, sir. Yes.
So that was a printing mistake I was talking about. Yes, Dr. Vikas, anything you want to
No, sir.
further, or any point, Dr. Isha, you want to we discuss more in
Yes.
detail, or nothing much? I think
Yes, sir. I think
methodology and all this thing is very clear. And fortunately, we know little bit, and unfortunately, this paper is nothing much giving input to our clinical practice as of now. Individually, we can. So individually, we do so many things over there. The nebulization of cholesterol. Even in the clinical practice, mesh nebulization is not being
available
practiced
everywhere.
in the all ICU. Now it is getting available, but not routinely practiced. What we practice is a very much questionable to the drug delivery to the intended area over there.
Yes.
So again, the clinical practice, we may not get the result over there.
Yes, sir. So if there is nothing to discuss, we can go ahead and conclude.
So I think that is clear to everybody. Of course, a last comment of for our viewer, they definitely go through this paper. How it is going to help you, first and foremost, how the study is designed for such type of observation and the outcome. That is again important, because the web we can express as a percentage, or maybe web rate according to the 1000 ventilator days, and how it should be compared. Web itself is a and similar type of other outcome they can plan their study. They have shown a good way to blind over there. So they blind at the different level, which is a
Hmm.
good way over there. The how the blinding was done, who prepare for the medication, who see
Hmm.
the things over there. So it gives you a reader some idea about the how blinding can be done over there. And third thing is uh, the discussion about the limitation of the study. Author discussed it very well. And lastly, it comes to the this paper has shown us some kind of a benefit. So individual patient one can see it, try it depending upon the circumstances and the situation. And as
Yes.
I again giving you emphasis, the clinical trial which gives you consistently excellent results with the same question with the little bit variations. And so to come into the actual practice, what is the journey of the research to the actual practices? A paper, research paper is being done, same or similar question in the different little bit scenarios over there. All this thing is appraised by different experts. Then
Hmm.
it goes to the society of relevant, then a panel of the discussion, they finally extract out, and depending upon their understanding and the clinical element is also put into the consideration. Then based upon that, how much they are convinced, so that they recommend in the graded way. And finally from that graded way recommendation comes into the your clinical practice, except the class 1, which is clearly showing the this thing is rest of the recommendation are the recommendation only, may not be
Hmm.
necessary you have to go about that. But this is the journey of how the evidence is generated and comes into the practice. I think with that we should
Yes,
close
sir.
the session.
Yes, sir. Yes, sir.
Thank,
Thank you. Thank
thank
Thank you,
you.
you
sir.
very
Thank you,
Thank
sir.
you for this. Thank you. Sahil, you can close.
So, sir, meeting is over.
Yes, sir.
okay.
Oh, thank you.
Thank you, sir.
Chalo, good.
Thank you, sir. Thank you so
Good,
much, sir.
Isha, your presentation is was really excellent. Somehow we
Thank you.
missed the Dr. Tapesh
Yes.
this time.
Thank you, sir. Thank you so much, sir.
Right.
Okay, okay, bye.